Tens of millions of adults wake up at night to use the bathroom, not once, but 2, 3, sometimes 5 times. And here's what most people never hear explained clearly. In a large share of those cases, the bladder itself is working exactly the way it's supposed to. The pills, the supplements, the herbs aimed at your prostate or your bladder, they're often aimed at the wrong organ entirely. It's 3 o'clock in the morning. The apartment is completely still. You'd finally sunk into that deep, heavy sleep, the good kind. Then the signal comes, faint at first. You try to roll over, try to think about something else, but the pressure builds. You throw back the covers, drop your feet on the cold floor, shuffle to the bathroom half asleep. You come back to bed and the sleep is gone, mind running, lying there for an hour, finally drifting off, and it happens again. You wake up in the morning heavy-headed, running on coffee just to function. If you've been told that's just age, everybody gets up at night, that's a common misconception, and it's worth taking seriously instead of accepting. According to the International Continence Society's standard definition, nocturia simply means waking from sleep at least once to urinate, with sleep before and after. Getting up once a night is worth paying attention to. Twice or more is worth a real look, because interrupted sleep isn't a minor inconvenience. Every time you wake, you cut into the deep sleep phase where your brain clears metabolic waste, and your cardiovascular system gets its lowest stress hours of the day. Chronic sleep fragmentation is genuinely linked to worse long-term cardiovascular and cognitive outcomes. That's well documented in sleep medicine research generally, even without needing a dramatic comparison to make the point. Here's the piece that surprises people. According to NIH's clinical reference material on nocturia, the single most common cause, found in the large majority of cases, isn't a bladder problem at all. It's something called nocturnal polyuria, your kidneys simply producing too much urine specifically during the hours you're asleep. Treating the bladder for that is like taping over a fire alarm because the beeping is annoying instead of finding out where the smoke is coming from. The bladder is the sensor. It's just reporting that something else is filling it overnight. Before we get into the mechanism, a few things that should send you to a doctor directly, not just to a video. First, blood in your urine with no pain. Pain plus blood usually points to a kidney stone or a bladder infection. Miserable, not usually an emergency. But dark red or brown urine, or clots with nothing hurting, is one of the classic early warning signs of bladder cancer that the American Cancer Society and major urology guidelines flag specifically because it's painless and easy to dismiss. In anyone over 50, that combination is a direct reason to see a urologist for an evaluation. Second, pelvic or lower back pain combined with unexplained weight loss of 10 to 20 pounds over a couple of months. That pattern needs medical evaluation, not home remedies. If neither of those applies to you, keep watching. But if either does, please don't wait on this video to tell you what to do next. Now, the mechanism. Urology divides nighttime urinary problems into a few distinct patterns, and the treatment for one can actively make another worse, so it's worth knowing which one sounds like you. This comes from the same International Continence Society framework used across urology. Global polyuria suffrage, you're producing a large volume of urine around the clock, day and night both, not just overnight. Usually one of two causes. You're simply drinking very large volumes of fluid throughout the day, or there's an underlying issue like diabetes, either high blood sugar pulling water out with it, or a hormonal condition affecting the brain's fluid regulation signal. This type needs blood work and a conversation with your doctor, not a home fix. Nocturnal polyuria, by far the most common pattern, and per NIH's clinical summary, found in up to roughly 88% of people with nocturia when researchers look closely at what's actually happening. During the day, everything is normal. A bathroom trip every 4 or 5 hours, nothing unusual. The moment you lie down, it changes. 3 or 4 trips a night, each one a full bladder. This is the type where the bladder genuinely has nothing to do with it. Reduced bladder capacity, the opposite picture. Urges are sudden and urgent. You rush to the bathroom, and almost nothing comes out. This is a real bladder or prostate issue, an overactive bladder, an enlarged prostate, a bladder or nerve sensitivity problem, and it responds to different treatment entirely. There's also a fourth mixed pattern where more than one of these overlaps, which is common enough that a proper diagnosis usually starts with a simple frequency volume chart, something your doctor can walk you through. Here's a pattern that plays out constantly in clinical practice, and it's worth walking through because you'll likely recognize pieces of it. A man in his mid-50s, healthy, not a complainer, finally comes in after months of 4 or 5 bathroom trips a night. He's already convinced it's his prostate. He's tried the marketed supplements, the herbal blends, and reasoned that if he's producing so much urine, he should just drink less. He cuts his fluids back hard during the day, and he still wakes up at 2 a.m. and again at 4 a.m., releasing a full bladder each time, having barely had anything to drink. His prostate labs come back essentially normal. His bladder is clean on imaging. From a purely urological standpoint, there's nothing seriously wrong, and yet he's exhausted and getting worse. So the questions shift away from the bladder. Any shortness of breath? Climbing stairs, for instance? A little, actually. Does his sock leave a groove in his skin by evening? Yes, now that you mention it, that combination points somewhere else entirely, toward the heart and the legs, not the prostate. And it's a genuinely common finding. Nocturia driven by fluid redistribution is well documented in patients with even mild early heart strain and with obstructive sleep apnea, both of which can hide with no dramatic symptoms until something like this makes them visible. A cardiology and sleep medicine referral, in a case like this, often finds exactly that. Let's walk through the physics, because this explains why someone who hasn't had a sip of water since dinner can still be up all night. Picture a bottle half full of water. Upright, the water sits at the bottom. On its side, it spreads out evenly. Your body works similarly with gravity. For most of your waking day, you're upright, and gravity pulls blood, lymph, and fluid between your cells downward towards your feet and ankles. In a younger, more active vascular system, vein valves hold that fluid in place, and the leg muscles, contracting every time you walk, pump it back upward. With age or with a sedentary lifestyle, that system weakens, veins stretch, valves leak, and the muscle pump goes quiet when you're sitting for hours. Fluid seeps out of the vessels into the soft tissue of the legs. NIH's own description of this puts it plainly. Your legs and feet act like sponges, quietly holding on to extra fluid you may not even notice, even if the outside of your leg doesn't look obviously swollen. Then you lie down. Your legs rise to the same level as your heart and kidneys. Gravity stops holding that fluid down, and it starts moving back into circulation. A real, measurable shift, sometimes over a liter, returning to your bloodstream within an hour or so of lying flat. Your heart notices, specifically, a hormone called atrial natriuretic peptide, or ANP, released from the wall of the right atrium when it stretches under that returning volume. Research on ANP in older adults with nocturnal polyuria, including a study looking specifically at elderly men with this pattern, found meaningfully higher ANP levels overnight in people with nocturnal polyuria compared to those without it, and raised the possibility that even subtle early heart strain can drive this hormone up. ANP's job, once released, is to tell the kidneys to increase filtration and dump sodium and water fast to take pressure off the heart. Your kidneys respond within the hour. That's the mechanism. Fluid quietly stored in your legs all day, cashed in by your kidneys all night, regardless of what you drank. So how do you check whether this is what's happening to you? No scan required, just your own hands in a few minutes. Test 1, the pitting test. Sit comfortably and find your shin bone, the hard ridge along the front of your lower leg with no muscle over it, about 4 to 6 inches above your ankle. Press firmly with your thumb and hold for 10 to 15 seconds, then release. If the skin springs back flat immediately, there's no significant fluid buildup there. If it leaves a visible dent that takes several seconds to fill back in, that's evidence of fluid sitting in your tissue. A standard physical exam finding clinicians call pitting edema. Even if your leg doesn't look swollen to the eye, Test 2, a simple frequency volume diary. This is literally the tool the European Association of Urology's 2023 guidelines recommend as a first step in evaluating nocturia. Pick one day off, get any container with volume markings. A measuring cup works. Track your urine output separately for daytime versus nighttime, including your very first trip after waking. By the International Continence Society's definition, if your nighttime output is more than roughly a third of your 24-hour total, the exact cutoff shifts a little with age, that's nocturnal polyuria. If you produce 1,500 milliliters over 24 hours, and 500 milliliters or more of that happens at night, that's your pattern, and it points to fluid redistribution or a hormonal shift, not your bladder or your prostate. If both come back positive, the pit stays, and your nighttime output is disproportionate, you can relax about your bladder specifically. What you likely need isn't a procedure, it's better circulation and a different evening routine. Which brings us to food. There are foods that quietly program your kidneys to do most of their work at night, and most people eating them have no idea. Here's the mechanism. Hidden salt. Around 70 to 80% of the sodium most people eat doesn't come from a shaker. It comes from processed and packaged food. Cheese, cured meats, sausage, mayonnaise, canned goods, bread. It's masked by fat and flavor, so you don't taste how salty it actually is. When sodium hits your bloodstream, your body holds onto water to dilute it. That's basic osmotic physiology. You don't notice it in the evening. Overnight, your kidneys detect the excess sodium and start actively excreting it, and because sodium pulls water with it, that excretion takes a real volume of fluid through your kidneys while you're trying to sleep. Evening sugar. A dessert or sweet snack before bed spikes blood glucose, which triggers an insulin response, and insulin, beyond managing blood sugar, also signals your kidneys to retain sodium and water in the short term. A few hours later, right around when you've fallen asleep, blood sugar drops and the kidneys flip into active excretion as a rebound. If you have any degree of insulin resistance, common after 40 and often symptom-free, elevated blood sugar itself pulls water into the urine as an osmotic effect. A late-night dessert can function like a mild diuretic a few hours after the fact. Alcohol. A nightcap does help you fall asleep faster. It's a real sedative effect. But alcohol is also one of the more effective blockers of antidiuretic hormone, vasopressin, the exact signal that normally tells your kidneys to concentrate urine and slow down overnight. With that signal blocked, your kidneys run at full speed unrestricted. The sedative effect may get you through the first urge without waking, but the bladder keeps filling until the second urge is unmissable, and the sleep you do get is shallower, missing much of the deep restorative stage. You tend to wake up more tired, with a fuller bladder, than if you'd skipped the drink. On the other side, a few things have real, if modest, supporting evidence for bladder comfort. Cranberry, the actual fruit or a standardized extract, not sweetened juice cocktail, which is mostly sugar, contains proanthocyanidins that make it harder for bacteria to stick to the bladder lining. This is genuinely well studied for urinary tract health. Pumpkin seeds have some smaller clinical studies behind them for overactive bladder symptoms specifically, via magnesium and plant sterols that may support pelvic floor and bladder muscle function. Promising but not as heavily established as the cranberry research, so treat it as a reasonable add rather than a proven fix. Fiber helps for a purely mechanical reason. A chronically full, gas-distended colon sits right next to the bladder and can compress it, making it signal full well before it actually is. Regular vegetables, whole grains, and adequate fiber keep that pressure off. Diet changes the biochemistry, but if your vein valves are worn out and your vessels have lost elasticity, food alone won't override the physics of where fluid sits. That's where a daily routine matters more. Morning, wake up the pump. Before coffee, before anything else, stand with feet shoulder-width apart, rise onto your toes an inch or two, and let your heels drop back to the floor with a light, firm impact. 30 reps, roughly 1 per second. That heel drop motion mechanically activates the same calf muscle venous pump that keeps blood moving against gravity all day. The same muscle system covered in leg circulation research generally, sometimes described as the second heart of the legs. If standing is difficult, there's a floor version. Lying down, lift both arms and legs and shake them gently for about a minute. It looks strange, but it engages the same drainage mechanism. Daytime, shift your fluid timing. Both NIH's clinical guidance and the National Association for Continence recommend front-loading your fluids. Aim for the large majority of your daily intake before mid-afternoon, tapering to small sips after that, rather than cutting off entirely. Thirst itself isn't something to ignore, since dehydration thickens blood and raises clotting risk. And take the salt shaker off the table. Salting only during cooking, not afterward, can meaningfully cut your daily sodium without changing what you actually eat. Evening, the leg elevation window. This is the single step with the most direct guideline support. About an hour to 90 minutes before bed, lie down and prop your legs up on a couch arm against a wall or with a pillow under your knees so your heels sit above heart level. Roughly a 45-degree angle is plenty. NIH's own Nocturia management guidance describes exactly this. After dinner, elevating the legs helps fluid pooled in the tissue return to circulation and become urine before bedtime, while you're awake and in control of it, instead of after you've fallen asleep. Stay in that position for 15 to 20 minutes. Read, scroll your phone, whatever. You'll typically feel the urge to go within half an hour, release a meaningful volume, and go to bed with far less fluid left to redistribute overnight. If you have visible leg swelling, graduated compression stockings during the evening hours can help too. Worn from when you get home until you shower for bed, not overnight. It's worth being honest about the evidence here. A recent pilot study on compression stockings for Nocturia found a modest but real reduction in nighttime bathroom trips and an increase in hours of undisturbed sleep. But the same researchers noted the overall evidence base is still thin and somewhat mixed. It's a reasonable thing to try, not a guaranteed fix. Before sleep, pelvic floor. Once you're in bed, lights off. 20 to 30 slow pelvic floor contractions done correctly. The common mistake is squeezing the glutes, abdomen, or thighs. That does nothing useful here. The correct cue is closer to imagining you're stopping the flow of urine or drawing the area between your legs gently upward while your stomach and glutes stay soft. Hold each contraction about 3 seconds, then release slowly. This is more established for stress incontinence than Nocturia specifically, but it's a reasonable, low-effort addition to a bladder-focused evening routine. Age genuinely changes the odds here. Vein valve function and vascular elasticity both decline gradually over time, and by some estimates, Nocturia affects up to half of men and women over 75, a very different picture than in your 30s or 40s. That's not a reason to assume nothing can be done. If anything, it's the reason this routine matters more, not less, as you get older. So here's your plan for tonight, in 5 steps. 1. Do the thumb test on your shin right now. 2. On your next day off, track your urine output for 24 hours and see what fraction happened overnight. 3. Clear the hidden salt out of tonight's dinner. Skip the cheese, cured meat, and heavily processed sides. 4. About an hour before bed, elevate your legs for 15 to 20 minutes. 5. Once you're in bed, 20 to 30 slow, correctly done pelvic floor contractions. And if the pit in your leg stays, if you're short of breath on stairs, if your socks leave a groove by evening, please make that appointment with a cardiologist or a vascular specialist rather than trying to solve it with this routine alone. Your bladder is a signal, not the enemy. Most of the time it's telling you the truth about something happening somewhere else in your body. You just have to know where to look. I'm William Tong. If this connected some dots for you, tell me in the comments which type of Nocturia sounds like yours, and how old you are. It genuinely shapes what I cover next. And if it was useful, share it with someone who's been blaming this on just getting older.